Ni hao, good morning, everybody. My name is Hassan from Saudi Arabia, King Saud Medical City, one of the largest center in the Middle East, and they are doing cardiogenic shock patients. My presentation about revascularization and cardiogenic shock, and I prefer to start with a case, and we can discuss the approach in this patient. So this is a 65 years old man who is having hypertension and dyslipidemia. He's having waxing and waning chest discomfort for 3 days. When he came to emergency room, his blood pressure was normal, the same for rest of vital signs. His physical exam was unremarkable, and we did an ECG, found that he had diffuse ST depressions with FER elevations, and we did some lab which was showing that the normal hemoglobin, the same for creatinine, and the same for lactate. However, his troponin was positive. So we elect to admit this patient as a case of non-ST elevation MI. We did an ultrasound of the heart, which was showing that ejection fraction is 30, and there was an original wall motion abnormality in the anterior walls. So we did an angiogram of this patient, and this is the right coronary artery, which was subtotal occluded from sloping.
Maybe you should.
Yeah, but it is like fast.
Yeah.
Okay, we need to go back to the line.
So everyone, you must.
Now we're good.
Yeah.
So back again, this is the right coronary artery. It's clearly that subtotal CTO occlusion of RCA from proximal and the mid part. There is 2 serial lesions at the proximal and the mid, and they get some collateral from ipsilateral or conus from left system. And this is how look like the artery from different view. Okay, so and this is the left system. When we engage the left main was damping pressures and was having diffuse disease at the proximal LCX all the way from the O cell to the mid portion. Long lesion, again the same lesion has at the proximal of LAD, showing at the cranial view, very long diffuse disease, different views. So different view again to the LAD and the LCX. This is from spider view, very long diffuse LAD. So this patient was, as I mentioned, was admitted as a case of non-ST elevation MI, and we calculate his syntax score, which is came to be 49, and the cardiac surgery team was accepting the case. And so far at this stage, this patient as a regular case, is not in shock, not in any hemodynamic instability. But as far as the patient was not in passing the red line of the operation room, still under general cardiology. So while he's waiting for his surgery, he developed chest pain, hemodynamic instability. For that time, we called the cardiac surgery back again, but they were not happy to take him to the surgery. So we'd like to take this patient to the cath lab as a case of cardiogenic shock. And this is our question is, this is acute kidney syndrome, non-ST elevation MI, cardiogenic shock, and MCS support. Should we do the culprit, or we should do complete all the vessels? And if it's yes, is it single sitting, or we should do it and stay? So as this patient, low ejection fractions, hemodynamic instability, we use the right femoral axis as for MCA support, and we like to use an Abella CP25 and was inserted smoothly. Then we start to IVUS the vessels and this is the point that I need to stress on. Imaging of the coronary artery is a class 1 indication in coronary artery disease, especially in complex procedure, and this is where we should make the cardiac surgery result in the CABG. A lot of study have been comparing uh, imaging guiding PCI with a different modality, and one of them lastly published by Prof. Lee, the CEO, and the comparing intravascular imaging with the CABG, and very interesting result that IFAS guided images associated with a similar risk of clinical event comparing with the CABG, and this is where we should competing lateralization of the CABG. So uh, so we did prepare the lesion very well, ballooning with different balloon sizing, and then we elect to do an double kissing callot approach in this lesion. So stenting LAD, stenting LCX all the way back to the left knee with the 3.538 onyx stent, then from left main to LAD with the two overlapping stent, 3026 and then 3530 onyx. Was optimizing kissing, and which this is result in the left system. Then back to our question, which is this is the result of the left system, and we see the right coronary artery very clearly from this picture. It is occluded. Before I move, I think already I discussed with our ones and colleague from Peking about what they are doing, and they said since 2007 they used to do complete, and then now changing in the China guideline to be 2B. So as we know that the patient who's not in cardiogenic shock very well studies that complete refast is consistent with the benefit in multiple trial, either in STEMI or non-STEMI, by different large trials, and either guided by imaging or IFR over an angiogram, is still consistent with the benefit. The timing of the procedure, either at the index procedure or after, it doesn't show non-inferiority or better at the stage versus immediate PCI. However, in the culprit, very well known studies that said it is class 3 indication to do multiple PCI at the same setting or routinely in the patient in cardiogenic shock, especially in non-STEMI, as our patient. However, this is coming from one of the landmark study in 2016 and 17 by Tyler, that is showing that they doing non-culprit vessel at the same setting associated with cardiovascular mortality and death and increase of renal replacement therapy. However, we need to deep dive in this study, and when we review this study very and try to reach to the point of multifocal PCI, mortality arm was higher. So we found that half of population they had an resuscitation in emergency room before they get to the cath lab, and in the multifocal PCI arm, there is a lot of them was driven by anoxic brain damage. Again, the CTO was very well representative in multifocal PCI group, and this is there is a like 19% of this population non-negligible contribute to increased duration and degree of complexity in the procedure of this group, and there is a lot of around 12.5% of crossover between two groups, either in especially in the culprit fizzle, there is some of crossover. Then the question of using MCS support in these people, they left it to the operator opinion, and ending by 28% of them was used, and 18 was only using the microaxial pumps. And this is one of the recent published study. It is one of the sub-analysis of danger shock, again in the people who have an culprit versus multiple PCI. The patient who's meeting the criteria of shock by danger which is blood pressure less than 100 or ejection fraction less than 45, non-comatose. They found that immediate multiple PCI associated with a significant low odds of all-cause mortality. And the next question was if it is complete revascularization or multivessel PCI, what is the meaning of complete? So there is one of them scoring, coming through culprit shock again, which is residual syntax score. If the fizzle more than 1.5 to 2 millimeter with a more than 70% stenosis, this cause called untreated fizzle, and this is significant lesion. When this score is high, is associated with mortality. When we apply it to the culprit shock again, it was the score of more than 8 associated with the worst outcome. And we found that only 25% of the patients who have multiple PCI approaching this score. So then the question is, it is single sitting or complete? And this is a lot of factors playing in this question. It's depending on the patient, complexity of the procedure, and renal function of the patient, the radiation exposure. So many factors that preferring of or supporting immediate multiple PCI, and some of them supporting staging PCI. And this is a schedule showing some of them what's favoring and what's not. Back to our case, this is the ACS, so we decide to complete the revascularization in this patient, even though so we open the fizzle, ballooning multiple timing, different balloon size. Then eventually we put in IVAS to measure the sizing of the stenting and the fizzles. We put 2 overlap stent, 3.0 and 3.5, 38 and 30, and this is our final result. Before I conclude my presentation, I would like to invite you to our upcoming large intervention conference in the Middle East, 27 and 29 November. And thank you for your listening.